questions that kind of got started from the previous training, we can see what we can do with that. But also, please feel free to reach out. It's always nice for us when we hear from people and, get to know some of you guys out there a little bit that way as well. Okay, so if you've been with me before or you were with us last week, you know that this is sort of an iffy moment where I'm going to try to share the screen. Technology is not my friend sometimes, so everybody just send me some good vibes and some positive thoughts and prayers, and I'm going to go ahead and try to share this so we can now see what I will be sharing with you guys. Let's see. Okay, hopefully everybody can see that, and please let me know if you can't. And we will go ahead and get started here. I'm going to jump right into this. Let me tell you a little bit about my background. Today's training is called the Foundations of Dual Diagnosis because, of course, in the 80 some minutes that we have together, there is no way that I could talk to you guys about every mental health diagnosis and every iteration of that with all the different intellectual and developmental disabilities. So what I really wanted to do today was to start out with just some background about what kind of incidents are we talking about? How frequently is this an issue that people may have an intellectual disability and a mental illness diagnosis at some point? And then we're going to go through some of the major diagnostic categories. There are, gosh, probably around 24 different diagnostic categories in the DSM-5. We're going to hit the top, I think 8 or 9, something like that. And I'm going to talk a little bit about how when we look at a diagnostic category, what are some of the variables or the factors that people may take into consideration when they're trying to diagnose someone. Some of you out there may be clinicians, you may be doing some of these diagnoses. Many of you I know probably will not be doing that. But I wanted you to be familiar with, if someone has received a diagnosis, what factors may have to have been considered. And many of you who are in a coordinating role or an advocacy role, I think it's helpful to look at what is becoming the gold standard, as people say, about how these assessments should be done. And if you are working with an individual where you think perhaps they have not been able to access somebody who's trained and somebody who is able to evaluate all of these factors, if you think that maybe they haven't gotten an appropriate diagnosis. And we'll also talk about some of the problems with polypharmacy and multiple diagnoses that can kind of stack up with people. Then you may play a really critical role in terms of saying, hey, I think maybe someone should take a second look at this, or I think we need to look at how some of these assessments have been done. Then we will talk about kind of one of my favorite things, which is how does the DD world and the mental health world come together? We share a lot of similarities. I always think of us as kind of like cousins at the family reunion, but everybody makes the potato salad a little bit differently, and that can cause some conflict. So how do we work with that? And ideally what this will do is, for some of you who are already working with dual diagnosis, this may be a helpful review. And as always, I would love to hear your experiences, observations, questions, any of those things as we go. And for those of you for whom this is maybe newer, I think this is a good way to think about the principles of dual diagnosis and how we might approach this, even if you go on to learn more about a particular diagnostic category, or you're working with, a particular intellectual or developmental disability. Just for the ease of use, I'm just going to use the phrase developmental disabilities. It just is a little quicker. But increasingly, you'll see that sort of intellectual and developmental disabilities kind of put together. Okay, so as Holly mentioned in my introduction, and thank you, Holly, so much, and thank you for hosting us. I come to this from a mental health background, and then in 2009, I got to be the project coordinator or the project manager, I guess, for the Coordinating Center of Excellence. And as I mentioned a little bit last time, what that meant was that I got to travel around Ohio, and I worked a lot with counties and Adam H boards, as they were called, and really learned about all these different ways that people were working with folks who were in both systems, and different approaches they used, different team orientations that they had. And it was so exciting, and I really, really loved it. And so it's really nice to get to come home to that a little bit with you guys today. And I hope this will be fun for you guys. We will take a break about halfway through, give or take. And as we've said, I will be leaving time somewhere around the break and then at the end as well to hear some of your thoughts as well. All right, so we're not going to spend a ton of time on statistics, but let me get into some of them. As I may have mentioned last time, I think I talked about this briefly, about a third of people who have some kind of intellectual or developmental disability are also going to be diagnosed with a mental illness at some point in their lives. Now, we're going to talk more about this later, but those of you in the mental health world know that a diagnosis may very well not be a lifelong thing. So when I say they may have had that at some time, it's really important to keep in mind, especially if you're sort of in the DD world, that someone receiving a diagnosis of, let's say, anxiety or depression or whatever it might be, may not always have that diagnosis. So for me, it's really important to put that in there, that there is sometimes a limit for how long someone might qualify for that diagnosis. Oops, let me do this. There we go. So in Ohio, we serve usually around 90,000 people in the DD system. And so if we're looking at people who rise to the level of needing developmental disability supports, that's going to be about 3,000 people. Where this gets a little tricky, and we should probably consider that these numbers are higher, is that there are many folks who have what we would call mild needs for support, or a mild disability that may or may not qualify for receiving the support of a county board, let's say, but would qualify as being considered to have some form of a developmental disability. And these folks are also highly likely to have some mental health diagnosis at some point. So that number is probably a little bit low. And when we're talking about folks who have higher needs for support in a developmental center in the DD world or in a long-term hospital setting, then those numbers are much higher. So there you're talking about maybe as many as 7 out of 10 people will have that dual diagnosis. So we know that having a developmental disability puts you at risk of having some kind of behavioral or emotional or mental health issue. Depending on what studies you read, it can be 3 to 6 times greater risk. Now, obviously, that doesn't mean that 3 to 6 times people will have it. It just means that their vulnerability does go up. This is important, I think, because some of you younger folks in the audience may not have experienced this, but if you are older, then for example, when I really started working with dual diagnosis, it was changing, but still not uncommon to hear people say that if you had an intellectual disability, you were somehow protected from mental illness. You weren't likely to have that. Some people felt that with higher needs for support, with greater cognitive impairment, there wasn't any incidence of serious mental illness. And we know now, of course, that not only is that not true, but it actually puts you at greater risk. So that's really important to know. As I said, we're going to be talking about some of the common diagnostic categories today, but we also think that it may put you at greater risk for some of the more unusual disorders like PICA, which is eating non-food substances. Okay, so it is tricky to diagnose folks with a mental illness or an emotional disability or an emotional challenge if they have significant levels of disability in other areas, because while I believe this is getting better, we don't always have the gold standard form of assessment tools that have been modified sufficiently. So for example, when it comes to suicide assessment We, for people, again, who are in that sort of borderline or high functioning range, those adjustments and modifications are relatively easy to make. When folks have more moderate or profound levels of disability, then it's harder. And I think we as a field are still developing this. So this is really important. Diagnosis for folks that may receive that dual diagnosis is often a longer process. It requires clinicians and medical professionals who have had some kind of training, in my opinion. And if it's been done quickly, or if you feel like people aren't very familiar with working with people with a developmental disability, then again, that's where I think that advocacy may need to happen, where, you know, do we get a second opinion, or does someone take another look at this? So some of these challenges I've already mentioned. As we go through some of the categories, and I've chosen one diagnostic category, personality disorders, to just sort of illustrate where these challenges come in. If someone is non-speaking, and that probably should say non-speaking instead of nonverbal. If someone is non-speaking, or communication is difficult for other people to understand, difficult for that person to communicate, then asking them to talk about subjective internal states like a sense of self, that can be hard to assess. If you go to the end of the slides, I've listed some, not everyone, because that would be, you know, slide after slide after slide, but I've listed some of the major sources that I've used for this. And one of them is actually, disclosure, my publisher, but the National Association of the Dually Diagnosed has now a second edition of their version of the DSM that lists some of the modifications that may need to be made in assessing or diagnosing things. So there are some tools available to folks, but know that when we're talking about the more severe forms of disability, it's always going to be challenging. There are other challenges in things like a clinical interview. So one issue is that, and we'll get into this a little bit, many people who have a developmental disability may have that as part of a larger, let's say, syndrome, right? So they may have, I don't know, Williams syndrome or Fragile X. And if you've got someone who's got a syndrome, sometimes that presents a host of medical complications. So they may have neurological complications, they may have digestive issues, you know, on and on and on and on. And that, again, makes it hard to sort of try to pull apart, is this an emotional problem? Are they behaving this way because they're in pain? Is this their neurological disorder? So it really requires some thoughtful and sensitive assessment. Now, I will also say, and this for folks in the mental health side of things, here's one of the things that I learned about DD that just kind of blew my mind. There is a wealth of information for many people who receive DD supports that we often just don't have in mental health, right? So if you work in, I don't know, a day program or a psych unit, and you've got round-the-clock staff who are taking notes and logging observations, then you've got some information to work with. But many, many, many people served in the mental health system don't have anything close to that. They maybe have regular therapy appointments, you know, if we're lucky. They occasionally are checking in with someone at a community mental health center. You know, they're getting med checks, things like that. Folks that have moderate to more supports in the DD world have lots of that information. They have staff, they have family members, many people have a lot of people who are paying close attention to this individual. So here's some good news for a change, that if you have someone who's dually diagnosed, chances are you have a wealth of information that can help when you are going through that process, which may take weeks or months, of trying to sort through what is it exactly that we're seeing here. Now, the next thing we're going to talk about is diagnostic overshadowing, which is a term that was coined at our very own Ohio State University, go Buckeyes, by Dr. Stephen Reese. And what he researched and identified was that when people have a mental illness and a developmental disability, they tend to be there tends to be sort of an attribution bias going on, where it can be that everything about me is sort of framed in terms of my developmental disability. So if I have dual diagnoses, and I'm banging my head, or I'm being aggressive, or doing whatever, then people around me might say, oh, that's just Lara because she has DD. Oh, that's the Down syndrome. Oh, that's the autism. Oh, and we talked about this last time, my personal favorite, Lara's just having behaviors. I still have no idea what that means. So everything is attributed to that. And people may not look deeper to see I'm banging my head because I have a raging sinus infection. And that's, trying to distract me from the pain. Or as we talked about last week, I have significant levels of traumatic stress and I'm freaking out because I'm triggered in my trauma. Everything is about the disability. Everything is about the DD, right? And it can go the other way, where nothing is attributed to having a developmental disability, and it's all attributed to a mental illness or medical condition or something like that. So it can really move in both directions. And again, really what it tells us is slow down, take some time with it, and use some of that information when it's available to try to tease out what exactly might be happening. And of course, you can have more than one thing happening at the same time. There are also interviewing challenges, and I think I may talk about this more on another slide, but I'm just going to jump into it here. If you've worked with folks with a developmental disability, you know that many folks have gotten very good at presenting the way they think people want them to present, which is super smart. As a clinician friend of mine likes to say, just because you have a developmental disability doesn't mean that you're not smart. So figuring out what people respond well to, being compliant, being, trying to guess the answer someone wants to hear, can absolutely create a challenge when you are interviewing someone for that clinical interview. So some common techniques to deal with this might be ask the same question a little bit later and see if it's consistent. Reverse the question. So you might say, it's probably not a great way to frame a question, but just to make the point, do you ever hear voices? So that might be like, yes, if they think that you want them to say yes, they'll say yes. And then later you might say, tell me about a time when you weren't hearing voices. I don't know, that's a bad example, but you reverse it. You also want to be careful about, if you're giving people choices, like sometimes, frequently, always, then pay attention to if they seem to be consistently just answering the first thing you said or the last thing you said. Maybe reverse the order in which you give those choices. Obviously, you may also have to simplify questions, or don't use metaphors and make things concrete. So there, again, this could be a whole training just talking about the clinical interview. But the point here is thinking about and paying attention to what is going on in that interview can catch some of these things that otherwise we might miss. Some assessment tools need to be modified, as we've talked about: placating or pleasing, confusing interview questions. Yes, this last one. Developmentally appropriate behavior may appear as symptoms. Keep in mind that a developmental disability, keep in mind the word developmental, right? That for some folks in their 20s, doing things that may be something we would expect to see in early adolescence or younger might be appropriate to them. But for someone who is neurotypical or who is, hitting their developmental milestones, it would look symptomatic. So again, these are just a quick way to talk about some of the different challenges and why not only do you want to take time with interviews, not only do you want to make sure that you're bringing in other reporters, staff people, family members, the folks who know that person best, but it's also really important that whether this is a physician or psychiatrist or psychologist, whoever it might be, nurse practitioner, that they have experience with working with folks with a developmental disability or who've gotten some additional training to do this. Diagnostic overshadowing, we talked about. Okay, so slides are not my thing really, but I've been working to jazz them up a little. So Enjoy. What? So exciting. Colors and movement. So trauma and stressor disorders, we've already talked about this. I would just remind people of a couple of things. Trauma is highly, highly present in this population. As we talked about before, some estimates have it more than 90% have some level of traumatic stress. And while someone can certainly have more than one thing going on, so for example, someone could have this next example, obsessive-compulsive disorder and traumatic stress, or they could have schizophrenia and trauma. Keep in mind that trauma will kind of turn up the heat on any of those other things. It will add to it. It will also add to medical conditions. If someone is walking around stressed out or checked out. Stressor disorders really just identify some of the other things that could be identified as a potential diagnosis, like acute traumatic stress, which is, I think, like within a month or so of the potentially stressful event, and adjustment disorders, which have milder symptoms, but seem to be a stress response to something going on in their lives. Obsessive-compulsive disorder, we do see this highly associated with some developmental disabilities. This is very commonly seen, for example, with folks that are on the autism spectrum. This includes stereotypic behavior. And that acronym there at the bottom, some of you may not be as familiar with, but body-focused repetitive behaviors, what we may also call like hair pulling, trichotillomania, excoriation or scratching, dermatillomania, any of those like sort of focused repetitive behaviors may be related to an obsessive compulsive disorder. ADHD, impulse control, and behavior disorders. You guys have been with me for a while now, so many of you know how I feel about behavior disorders as a diagnostic category. I think they're poorly conceived. I think when we diagnose someone with a behavior disorder, to me, it's just something where we can easily start seeing issues around bias. Is this kid being a pain in the butt to me? Is this person kind of scaring me with what they're doing? I do feel like we don't see great fidelity in some of these diagnoses, but I'm going to put them up there. And ADHD for sure is something that we can see a lot of with folks that also have a developmental disability. But ADHD, as many of my mental health peeps know, if you guys work with trauma can look like ADHD on any given day, right? So again, we're just coming back to that imperative that we really need to slow down and consider all the different things that can be going on here. Anxiety disorders, depressive disorders, bipolar disorders, generally speaking, we could group these into the mood disorders. These are some of the more common diagnoses in the general population. And yes, we see them commonly in people with developmental disabilities as well. Keep in mind that people who have, let's say, moderate support needs are very dependent on other people. And so what may look like anxiety, or even when we get further along and we talk about paranoia, in terms of I'm going to be abandoned, people don't like me, I'm not going to get what I need, that may not be symptomatic so much as it is an accurate reflection of their situation. So that's another one of those adjustments that we might need to make. Is it a symptom, or is this person's reaction understandable and realistic? Depression can, again, appear frequently in this population. This is not a training about grief. That is a training that I would love to do with you guys someday. Because I think that dual diagnosis and trauma is something that increasingly around the state and around the country, people are more and more aware of, which is wonderful. Grief hasn't quite come into its own yet with that. And I would say that those are sort of, I guess I'm going to imagine a stool here, but if you could imagine a three-legged stool, I would put mental illnesses, trauma, and grief as sort of the three legs. So my point here just is to say that when diagnosing depression, as many clinicians already know, the current DSM, the DSM-5, took out an exclusion that used to say if someone was grieving, I think the previous one was within a year, 6 months or a year, then you might hold off on a diagnosis of depression, because grief and depression in the early stages can look similar. The DSM-5 did get rid of that, although it does have some really helpful language in there in terms of how you might distinguish those things. We don't have time to get into that today, but I will point out that people with developmental disabilities, especially those who have significant supports, are more vulnerable to the devastation that a loss can bring. So a loss by death, a loss of staff who've moved on. Many folks who are in the DD system have fewer supports. They have less robust networks around them. And so a loss that we might not even think of as significant may very well contribute to either trauma or perhaps some depressive symptoms or even a full-blown depressive episode. So that's another thing to sort of keep in mind, is the intersection of those things. Bipolar disorders, I will just briefly say here that bipolar is one of the top 3 or 4 that can actually be trauma. But on any given day, if you're seeing what look like mood swings that are actually triggers, then people can be diagnosed with bipolar disorder as well. Moving briskly, I know we're going very quickly, so please let me know, maybe during the break or at the end, depending on how much time we have, if you want me to come back to this. The schizophrenia spectrum and psychotic disorders, for those of you who are not familiar, that would mean things like schizophrenia, psychotic disorders or psychotic disorder not otherwise specified, schizotypal schizoaffective, which is schizotypal is when it's linked with, I believe, obsessive-compulsive disorder. I'd have to check that one. That's a more rare form of it. Schizoaffective means that someone seems to have a schizophrenic disorder and bipolar disorder at the same time, which is a very hard road for those folks. So we do see higher rates of some schizophrenia spectrum disorders in this population. Here again are some tricky elements to consider. So for example, we talk about attending to internal stimuli. Basically, someone is seeing things or hearing voices. Well, especially if they are non-speaking, that can be kind of hard to discern. And if someone seems to be looking around, are they seeing things that I can't see? Or do they have a neurological disorder or a tic that's making them do that? That's going to take some time to suss out. In terms of voices, this one in particular merits some attention. So remember when I said that things that may be developmentally inappropriate for someone without a developmental disability may absolutely be developmentally appropriate for someone who does have one. So are we talking about someone who's hearing voices? Or do they have an imaginary friend, which again, for them would be appropriate? Now, not to go too far down this rabbit hole, but here's some pointers for how people begin to think about that. So you might look at, does this person seem to enjoy the conversations, or do they seem distressed? Are they able to break off that interaction that they're having and focus on something else, or does that seem to be out of their control? So there are ways that we can start to distinguish those things. Let's see, we are gonna keep going here. Substance-related and addictive disorders. Oh, this, again, it could be its own training. So here's the deal. There's a little bit of a paradox here. If you look at rates of disordered substance use or potentially problematic substance use in people with developmental disabilities, you will see the highest rates in folks that have mild impairment or are sort of on that borderline. The more supports people require, the less access they typically have to substances. So we do see those rates start to drop. If they are in, let's say, a group home, or they are in their family home and people can keep an eye on that stuff and limit their access, we are going to see less substance use. But studies do indicate that we will see higher rates of that in people who have that sort of mild support need. And this is kind of tricky, but I think I'm saying this right, we will see higher levels of negative consequence for substance use. So for example, there were, especially when I traveled to areas of the state where there were smaller counties, and in a lot of those places we would see kind of, collaborations or cooperation where there would be multiple counties in a region that would be meeting to support dually diagnosed individuals. And those were some amazing teams who were doing some of the most creative stuff. But in those situations, they would have what we would sometimes affectionately refer to as the Cheers clients. Everyone knows their name. So this is somebody who is known to the local mental health systems. They are known to the local DD providers. And unfortunately, they were often also known to the local law enforcement. These were folks that would go to a bar, drink, become, obstreperous or disruptive or whatever, and they would get picked up. Now, the good news about that is that when it was a small enough town, you really could do some good planning and supports when you could sort of get everybody around the table and figure out how are we going to support Kevin when he's got these things going on. The bad news is that, and this starts to be true in larger areas, there's not always that communication between systems. And so you may see individuals with dual diagnosis who are landing in jail, who are having a lot of problems with law enforcement, possibly fueled by substance-related issues. Yeah, I could go on about that, but I think this is a good place to stop, and we can come back to that if we need to. Autism disorders. Yup. We absolutely know that being on the autism spectrum, or as people are now talking about it, the autism wheel, or circle, or however you like that. I think that's kind of a cool way of talking about it. There is a much higher risk than in the general population for many of these, especially things like depression, anxiety. As I said, obsessive-compulsive disorder can be highly related to this. Some of those body-focused repetitive behaviors, really any of these things. And I think, now this is just my clinical experience, that people on the autism disorder, when they have low support needs, we may see some of that kind of diagnostic overshadowing in reverse. If they're highly intelligent, we may not think of them as having an intellectual disability, because they would not qualify for that. They may have a very high IQ, they may score very highly on multiple instruments for that, but they do still have a developmental disability. And in my experience, when someone is highly intelligent, it is easier, on or off the spectrum, it is easier to sort of dismiss or discount distress that they may be in or struggles that they may be having. And especially if this person maybe struggles with expressive language and talking about emotions, it may be hard for them to communicate, yeah, I'm super anxious, or I feel pretty depressed. So that's something to keep in mind there. Autism is its own field of specialty, and we're just touching a little bit on the borders of it. Personality disorders. These are where things get tricky. Some of you in mental health know that personality disorders are in and of themselves, there's some controversy around that. Because to be completely honest with you guys, I hope I'm not telling tales out of school for those of you who aren't in the mental health world, but it's really hard to say exactly what personality is. It's really hard to say how that's formed. So this is another one of those diagnostic categories that I think there's some useful things in these categories. The ones that most of you guys are going to be familiar with are in what we call the cluster B category, grouping, which is everybody's favorite. Let's see if I can remember it. Antisocial personality disorder, narcissistic personality disorder, used to be histrionic, but they got rid of that with DSM-5, and borderline personality disorder. Dun, dun, dun. So for example, with borderline personality disorder, we're going to talk about that a little bit more later because I chose that one as an example, but there are people in the trauma field who believe that all complex PTSD is really trauma. I'm not sure I believe that 100%, but I know that many people who are being diagnosed borderline are probably really people who are primarily grappling with trauma. And there's some discussion that with that one in particular, we're thinking about kind of retooling it maybe in future iterations. So we'll save that conversation for later. But here, just as an overview, as I mentioned, it gets hard to diagnose this because so much of personality disorders has to do with how people see themselves, how they experience their internal sense of self or other internal states, and how they experience other people. And that can be hard to figure out, especially when we're talking about more profound levels of disability. So again, we are told that there is a higher incidence of personality disorders in this population, but as we go further along on that spectrum in terms of levels of support needed, it gets pretty hard. The other thing that can sort of confound this is that, again, as my mental health folks know, personality disorders cannot be diagnosed until the age of 18 because it's considered that the personality hasn't fully formed until that point, which makes sense. But if someone is developmentally delayed, how does that work? So there are multiple authorities on this in the DD world who suggest that you really should extend that. Some people have suggested age 23. I don't know how you would arrive at that. But it just throws another one of those wrenches into that. So we're going to talk a little bit more, and then we'll probably take our break about halfway through. As I've mentioned it from the very beginning, you can see with every diagnostic category some of the complications that can arise. So, for example, one handbook for physicians and clinicians listed 20 different behaviors, things that we would typically describe as a behavior, and identified potential underlying medical, primarily medical issues. Now, there were some psychiatric issues that were thrown into that list, but as I went through this handbook for doctors, psychiatrists, whomever, 20 of these behaviors were, consider a seizure disorder, consider a metabolic disorder, blah, 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 blah. So that's just one little example of why a good biopsychosocial evaluation is needed. You can't just look at them medically. You can't just look at them from a psychological perspective. And you can't just look at them in terms of, when I think of social, I think of, functioning in the world, how other people are experiencing them. You've got to put them all together. And generally speaking, it's best if that physician has had some formal training or lots of clinical experience to do that. A colleague of mine who works at the OSU Medical Center Medical School is working to develop protocols for students to be exposed to patients with developmental disabilities as they are learning to diagnose, and helping people to be more competent with that, even if DD does not become their specialty. So we are seeing, I think, an encouraging trend in psychiatry and in medicine to identify and be more skilled working with this population. I'm going to point out here that, as I said earlier, you guys might be the people who are sort of the whistleblowers to point this out. And this is probably the last thing that I'll leave you guys with before we go into our break. There are two issues that make this incredibly important. The first one is polypharmacy. There are multiple studies and clinical anecdotal reports from physicians of getting patients referred to them who have not just one or two antidepressants. Again, clinical folks out there know that it's not that uncommon that you might have an antidepressant, but then you add a little something to kind of help fill in the corners or boost this or that function. That's not unusual. But if you have a developmental disability, you are at risk for having 3, 4 antidepressants plus a mood stabilizer, which is contraindicated for many people. So we can see multiple meds. And one of the reasons for that has historically been, especially if you get someone who moves from region to region or county to county or provider to provider, which people are at risk for in this group, that doctors or nurse practitioners or whoever is encountering this patient may be reluctant to take away something, so they just add. And there have been clinical reports from physicians of folks who have been described to them as non-speaking, non-verbal. And then they looked at their medication list and went, yeah, if I were taking all of this, I wouldn't be talking either. And that's when we start moving towards that line of chemical restraint. I'm going to be really honest. I think sometimes that's what's happened. Or we've had medical folks or clinical folks who have been reluctant to take medicine away. Now, to be clear, these are complicated folks. Medication issues are complex, and you definitely want to be moving conservatively and slowly. That is my non-medical understanding of this, talking to people who are medical professionals. But slowly and carefully does not mean never changing anything or just adding. We also know, and I mentioned this from my previous training as well, that if you have a developmental disability, you are at risk for much higher doses. Some studies suggest you have 6 times the risk of being over-medicated, not based on your height, weight, body shape, metabolic issues, whatever, the way you would normally be prescribed a dosage, but simply because you have a developmental disability. So we see polypharmacy, we see overdosing, and we also see multiple diagnoses. So just to give you guys an example, when we travel around the country, it is not uncommon for a county or provider, whatever, to say, hey, we've got this individual. Can you use this as sort of a teaching case for some of these things that we're training? And which is always fascinating, and I'm always happy to sort of jump in and have those conversations. And I will sometimes be shown someone who has, let me see, ADHD and obsessive-compulsive disorder and schizophrenia and depression and bipolar disorder. Well, that's a lot, right? That's a lot of stuff happening with one person. Now, I can't say that it's not possible to have all of those things going on, but it seems just common sense that we know about a lot of overlap with those diagnoses. Notice I didn't list trauma because trauma is still underdiagnosed. So we know 2 things. Trauma often can look like any one of these diagnoses. So that's rule out issue number 1. Issue number 2, really? This person has all of those things? So again, what I think we see here is that someone will see a new set of behaviors or a new presentation, but they may feel weird about ruling out something that's been previously on their record. So if you've seen people go to provider after provider after provider, they start to have this laundry list. So all I'm going to say is those are the things that make this not just interesting or helpful to know, but in some cases critical if you are the person who's saying, well, maybe, but can we take a second look at this? Or can we get another opinion about this? Or let's look at the kind of assessments that were done, and is there anything newer, or can we just take a closer look? Yeah. So that seems like a good note on which to leave this. We are at, let me see. Oh, perfect. We're at about 10 till. So I'm going to take one moment here to check out the comments and questions. We'll take our break at 10 till, and we'll come back on the hour. So let me pause the share here and go to the question section. Asking for slides. Histrionic personality is still in the DSM-5. Huh, that's interesting. I thought they dropped that. I'll have to double check that. There are also issues with using seizure meds like Depakote as mood stabilizers, a lot of polypharmacy that might not be necessary from Kimberly Farrell. Absolutely. Now, again, not to get into the technicalities here, I definitely see Depakote used as a mood stabilizer, especially when I worked with teenagers. So that in and of itself may not be bad, but it does mean when you're going off label like that, a good sensitive prescriber can do that and work in a very individualized way. But if you're not getting that, or you're getting, they've seen this person and then this person and then this person, then we can really start to have problems, including toxicity. I've talked with physicians who've seen people with irreversible tardive dyskinesia and other problems because of over prescribing and over medicating. Truly, Nicole talks about there are times when she believes it's medical restraint for behaviors. I agree. Do I have a list of clinicians who specialize in DD who are accepting new patients with Medicaid? Oh, Amy, I wish. Nope, we don't. But I do believe that this is improving. Nicole, most of the time, this is a trauma situation. No one took the time to look at the trauma and instead medicate for ADHD, OCD, and anxiety, etc. Yes, Nicole, I 100% endorse that. So thank you guys so much. Please take your break, get up, walk around. If you have other insights or observations or questions, go ahead and put them in that section, and we will come back here at 11. See you guys then. I know there are going to still be some folks jumping back on from the break, which is totally fine, but I have such a brief amount of time with you guys that we're going to go ahead and start. And I've been looking at the Q&A section. Great comments, you guys. There was one question about a neurotypical 4-year-old girl who experienced some trauma around a fire, which I was very sorry to hear about. Lori, obviously, I would not want to comment in more detail. That certainly wouldn't be appropriate, but I will tell you a couple of things. Kids that age really do well with family trauma therapy because the family is still pretty much their whole world. So that's usually a best practice. I would certainly consider at least getting her therapy with your niece at the same time or other family members all at the same time or whatever. A lot of play-based therapy can be really helpful for kids that age. So I would look for a good family therapist, and ideally maybe one who uses play therapy or perhaps a play therapist, but really with that family focus. So thank you so much for that question. Please go ahead, put any other comments or questions you have in that section, and I will let some time leave some time at the end so we can jump into some of those. Thank you guys so much for that. So let me go ahead and share my screen, and we will go ahead and wrap up our very brief time today. I don't have as much time with you guys as I would like to talk about behavior, but I will just say this. As I've mentioned, kind of in sort of a light way in our previous time together, I do think that mental health and developmental disabilities approach behavior a little bit differently. And understandably, for folks in the DD world, behavior has a much bigger profile because for some folks, that's really all you get to work with if they're non-speaking or if it's hard for them to communicate emotions or whatever that might be that we might normally kind of balance a little differently with someone who's neurotypical. Having said that, I do think the problem with that is that sometimes behavior interventions kind of just start and end with making someone behave better, which reminds me a little bit of one of the comments about trauma and young people in our Q&A section. So the other issue is that when communication is not such a barrier, sometimes people with developmental disabilities have been discouraged from expressing negative emotions. That's part of a much larger training that I do about helping people interact in a more constructive and supportive way. But I will say that if staff people or family members feel uncomfortable with someone being angry or sad, if they feel like they can't quickly make it better for that person, if they treat the feeling as a problem, which many people do, if it creates anxiety or distress in them, then people can directly or indirectly, sometimes it's pretty direct, discourage people from expressing emotion. As I've mentioned before, as part of another training, this is a huge issue with grief. It is not at all uncommon for me to see behavior plans or whatever, support plans, where staff are told to redirect someone if they start talking about someone that has died that they miss. They avoid sad movies or whatever. Now, I don't want to comment on, individual specific situations, but I will just say that I think sometimes we are making it hard for people to communicate emotion that they might otherwise, with some support and language, be able to communicate to us. So keep in mind that when someone cannot, either because of their own stuff or maybe the discouragement of the people around them, express their full range of emotion, what doesn't get talked about is going to be demonstrated. when I supervise staff and they would talk about someone acting out, I would usually suggest that they added the word it. So now this student or this individual is acting it out. They are showing us with their behavior what life feels like inside for them right now. So much to say, so little time. Yeah, okay. So I loved this quote. Aggression may be the final common pathway to identifying adjustment problems, physical distress, and emotional issues. That whole list of things that I went through that could be going on with someone medically, that could be going on situationally, and we're going to include grief and trauma as situational or adjustment issues in that sense, and emotional problems. All of these things may end up being expressed as aggression. And too often, people just target making the aggression stop. Now, I want to be very clear. We can't have people being aggressive with other people or themselves, right? So that obviously may often need to be the first thing we do, is to get them safe or to get other people safe. But all too often, it's the last thing as well. And I think that when we are seeing aggression or any other behavior pattern, we need to inquire more and not just be satisfied with, oh, the behavior's gone away. That's all we need to do. Some symptoms, this could have been days of slides for you guys, but I tried to grab some things that might get people's attention to look more in terms of either an emotional disturbance or a mental illness that has not yet been identified, or perhaps a worsening or a change in that for someone who's dually diagnosed. Changes in eating, changes in sleeping, sexual dysfunction, a lot less sex drive or a lot more. So for example, with bipolar disorder, one set of symptoms that we may see frequently with folks with a developmental disability is heightened affect display, like a lot of silliness, and heightened sexual behavior. So, they used to masturbate privately in their room, and now they're doing it in the living room 4 times a day, that kind of thing. That kind of, disinhibition, low energy, chronic unexplained pain. Well, any of my mental health folks out there know that these also are sort of, right on the list of things that we would look at for anybody as potentially having an emotional issue like depression, like anxiety. Cognitively, along with everything else, we could just say that any change from what is normal for somebody. So if memory is typically a problem, memory lapses are not going to be an issue. But if we start seeing more memory lapses, and another point here is that people with developmental disabilities also can have a higher risk for dementia. So really wanting to pay attention when we see some of these changes. Increased difficulty making decisions, decreased ability to concentrate, distraction, restlessness, agitation, spontaneous crying, despair, and hopelessness. Yeah, I would definitely want to look at that. Panic attacks, fearfulness, irritability, anger, numbness. Again, some of these things you start to see that with people with mild levels of impairment, they might be able to verbalize these beautifully. For folks that have greater levels of impairment, some of this stuff like emotional numbness might get kind of tricky. Withdrawal from normal routine in relationships. I have been just astounded by the sensitivity of people around folks with severe or profound disabilities and their ability to read someone's functioning and routine and relationships, even when that person is largely immobilized, maybe is non-speaking. Truly, there are some amazing resources that we have. So this is just another ad probably for making sure that that all the folks who are around that individual a lot have an opportunity to share their observations, because they may detect very subtle changes that somebody who's just meeting someone for a couple of hours will not be able to identify. Non-compliance, I probably qualify as non-compliant a lot of the time. So again, we're really talking about a change should get someone's attention. Increased aggression, screaming, disintegration of verbal skills. This is an important one. Verbal skills are neurologically really complex. And when someone is struggling with that, that's something that we should really be paying attention to. This could be increased seizure activity. There could be a lot of reasons why someone's verbal skills may be decompensating. So we really need to look at that. Baseline exaggeration is really what I could have called this whole set of slides. It just means what's normal for them is either a lot more or a lot less. And a reversion to institutional behavior if someone has been deinstitutionalized. So someone has been moved out of a, let's say, developmental center into a small group home in the community, and we suddenly see them going back to behavior that maybe was contextual previously. So hoarding, stealing, aggression, those may be things that they learned as coping strategies in an institutional setting. And we're suddenly seeing a reemergence of that. That can indicate an increase in distress. That can indicate triggers into trauma. That can indicate unidentified grief. It can indicate really any manner of things. We just need to be paying attention to it. Okay, and now I'm going to zoom through all of these because we've really talked a lot about all of them. And I'm going to take just a few seconds to look at some considerations. This is from, I think it's actually from the first edition of the DSM-ID, in an attempt to help clinicians adjust how they might be going through an assessment or a diagnosis. So I've chosen a few criteria from borderline personality disorder, frantic efforts to avoid real or imagined abandonment. People with intellectual disabilities are generally more reliant on caregivers than other people. And so their frantic efforts to prevent this have a different context. And that has to be accounted for when you're looking at this person going, gosh, why are they so, intensely seeking connection? Or why are they blowing up this relationship to deal with the distress of possible abandonment? Another one, identity disturbance, markedly or persistently unstable self-image or sense of self. It might require fairly overt, sophisticated verbal skills to talk about this. So again, there are some folks who can do that beautifully. There may be other people where that is difficult, if not nearly impossible. Recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. I'm going to talk about suicide separately in a moment. But when it comes to self-injurious or self-mutilating behavior, it's a frequent, well-documented problem in this client group, and there are multiple reasons why people might be doing this. So again, this can be reenactment of trauma. This can be an effort to get a serotonin release due to chronic pain. This could be more of like a, if I have body-focused repetitive behaviors where I'm excoriating, I'm scratching or picking my skin, and I do it to the point that it's harming my skin, that I'm getting infections or that I'm, getting scarring, it can look like self-injurious behavior, but actually it's a body-focused repetitive disorder. That's a lot of letters to say all at the same time. You guys kind of get it. We're going to jump ahead here. Talking briefly about suicide. It is a myth that, frankly, fortunately, is I think, dissipating. I don't hear it nearly as much as I used to, that people with developmental disabilities can't kill themselves or have enough protective factors. In fact, and there are not enough studies, but more and more studies are coming out, some small, some larger. Suicidal thoughts, suicidal planning, and suicidal attempts are higher than the generation, or higher than the general population, maybe by nearly 50%. One study that ranked suicide attempts and suicide deaths for all kinds of physical and intellectual disabilities, so that included things like spinal injuries, MS, things like that. Suicide risk ranked third of all the different disabilities that someone could have. So what we see here is that there are some things that are typically considered protective factors. Relationships, having a stable place to live, people around you, that some folks with developmental disabilities may in fact have. For example, some folks with developmental disabilities live in a house with roommates and staff 24 hours a day. So we might normally see that as an insulating or a protective factor compared to someone who has high levels of isolation. And that's true. But there are other stressors about having a developmental disability that may kind of mitigate some of that protection. We do see that as IQ, which is only one way of thinking about a developmental or intellectual disability, but for that one marker, we do see that as IQs go down, we may see more attempts and gestures at suicide, but we see fewer deaths because they may lack an understanding of what will actually cause death. So we may see someone, for example, swallowing coins, which is unlikely to be lethal, but is certainly a suicidal gesture or a suicide attempt. So it is incredibly important that we pay attention to this. People, for example, on the autism spectrum have in some situations, according to some studies, maybe 4 times the risk of suicide. And we see that go up for women on the autism spectrum more than we see that go up for men on the autism spectrum. So this, again, in and of itself could be a whole day of conversation, but it was really important for me to kind of put that in front of you guys. We know that, and again, there's never as much research as we would like, but I am seeing more of these studies in different areas, that therapy that is widely offered for the neurotypical world can, with modifications, be equally effective for people with developmental disabilities. I just chose a few here that I've seen actual studies for, but this has been repeated in multiple studies using different modalities. So there are several good studies now for doing, again, slightly modified forms of both individual and family supported EMDR for people with DD and trauma, and those have had statistically similar success rates. There's been widespread use of DBT for people who've been formally diagnosed with borderline personality disorder, but also for people with forms of emotional dysregulation where maybe that borderline diagnosis has not been given, and DBT has been seen to be highly effective for that. We've seen forms of group therapy for working on social skills that works very well. So depending on the group and the level of support needed, these may be smaller or larger modifications that will need to be made. For example, a common one is maybe doing shorter sessions. People may not have the attention span or the ability to sit for, a typical 50 or 60-minute therapeutic hour. But these are, I think, by and large, very doable, accessible ways that we can adapt what we're doing to make this work for people with a wide range of developmental disabilities. And finally, as I said, I wanted to talk briefly about how do we make this all work? So I like to think about DD and mental health and addiction as sort of different cultures. There's a lot of overlap, but there are some differences as well. So for example, in mental health world, things that people are dealing with may absolutely be chronic, right? So if someone has a severe persistent mental illness, like schizophrenia, that is likely, not always, but likely to be a lifelong diagnosis. However, some things like depression may absolutely be episodic, and once it's treated, they don't have a recurrence of it. And even with chronic conditions, we see periods of better functioning and periods of worse functioning. We often use things like hospitalization briefly to improve functioning. So that could be a psych unit, that could be a brief intensive day treatment, that could be inpatient detox, or whatever. And as I've sort of already alluded to, there's a rehabilitation model, meaning people can, in some situations, go back to their previous level of functioning before they had the episode of depression, or once their bipolar disorder is well managed with medication and therapy. So we can see full recovery or at least remission. All right, now let's look at folks in the DD world. A developmental disability, by definition, is something that happened during the developmental part of the lifespan. I believe in Ohio, the cutoff age is 22. So if it's been an injury or an illness that has created significant impairment, that has to have happened somewhere 0 to 22. And it is considered to be lifelong. People don't recover from having Williams syndrome or Down syndrome. This is something they're going to have potentially with stable or sometimes worsening impact over the lifespan. They're not going to get hospitalization to improve their functioning significantly. Now, when we're talking about people with dual diagnosis, they may get hospitalization to stabilize their recently identified bipolar disorder, but they're not going to go to the hospital to get improvement for their Angelman syndrome. They may need hospitalization for medical support for medical problems that come along with it. But in terms of cognitive function, that's not going to be treated in that way. And therefore, they have a habilitation model of support, meaning we are going to put supports in place and do everything that we can do to get you to the best level of functioning that we can. But there's not that same goal of full recovery. And generally speaking, in terms of the full constellation of effects from, let's say, a chromosomal syndrome or whatever, that's pretty stable. We're not going to see big changes or big improvements. People can absolutely improve in terms of their daily functioning, in terms of skill acquisition. We know, for example, that when people are in healthy and loving romantic partnerships, which is not always easily made available to people with developmental disabilities, then we do see big improvements. But they're not going to suddenly go from having that Down syndrome diagnosis to no longer needing it. Okay, so how does that create clashes? In my experience, where I see the two systems kind of running into each other a little bit, a frequent point of contention is accessing emergency services. One of the things I heard over and over again when I would travel around the state and to different states around the country later on was, man, our individual, clearly was not doing well, and we wanted to get them admitted to a psych unit, and we couldn't get them admitted. And then the mental health people in the room usually just start chuckling because they know that they can't get their folks admitted for psych hospitalizations when that might be helpful. Generally speaking, depending on where you are and what resources you have available, crisis or full hospitalization into a psych unit is probably only going to happen if someone is absolutely psychotic and or is presenting an immediate threat to themselves or other people. So they're gonna be suicidal, actively suicidal, homicidal, or in a full-blown psychotic episode. Obviously, I can't say that's 100% of the time, but generally. Now, this is something that in the mental health world, we're fairly familiar with. This can sometimes be a very unpleasant surprise for people in the DD world. So that can feel to them like, well, you're just not taking our people. Which is not to say that there aren't problems sometimes with getting a psych unit to take someone with a developmental disability because they are not admitting them when they should, who is suicidal or homicidal or having a psychotic episode or what have you. But that's an example of where, there's sort of a culture clash there. Trying to get qualification. This is how it works on the other side. I know from being in the mental health world, people that I felt confident would benefit from some DD support. I didn't fully understand sometimes how to access getting them assessed with the OEDI or the COEDI in Ohio. And I didn't understand why someone who, was kind of in that borderline range wasn't going to qualify to get supports, even though it seemed clear that there were some cognitive issues. The first one, or the next one I've already talked about a lot, we operate on different timelines. So in the DD world, we expect that, broadly speaking, someone is going to be treated, as they sometimes say, cradle to grave. They are going to be supported and cared for in our system. And I think both in mental health and in addiction, there's much more of a catch and release program, right? When we're talking about higher levels of support, like inpatient or hospitalization, that's probably going to be a pretty brief stay. And where that often comes into question is, let's say you've got someone who's dually diagnosed and their team their DD folks have been trying to get them mental health services, let's say counseling. And they go to the local mental health center, whatever, mental health provider, and they get that person counseling. Yay, so excited. And then 6 months, 9 months later, the clinician says, well, we've met, treatment targets and they're doing a lot better, so we're closing the case. What? I think there can often be an expectation, maybe sort of half aware that people have this expectation that this is going to be a long-term involvement. And sometimes it is, but because of the mental health world, it is often likely to be a fairly short-term relationship or intervention, and that can be very frustrating and confusing. Oh, and then the last one of the things that I saw was that there were a lot of roles that sort of paralleled each other. So an SSA in the DD world is kind of like a CPST sort of case manager and service provider in mental health, but there are some differences. And so, for example, you also have things like, oh gosh, I forget all the letters, but QSPs, I can't remember what they are, QRPs, whatever, behavior interventions. DD has a lot of acronyms, and there are a lot of people who are sort of on that kind of comparable middle level of involvement the way we would think of in mental health, but there are more of them in DD, and the roles don't always line up perfectly. Somebody can jump into the comment section and help me remember some of those acronyms. So what do we do with this? How do we get along with each other? Well, we do frequent collaborations like this one. So this is a great moment to thank ODMHAS and DODD for putting this on, Elena and Holly for coordinating this. This really is incredibly helpful when people get a chance to become more familiar with the other folks that they're potentially working with. There are very helpful system crosswalks and asset access trainings. When I was running the Coordinating Center of Excellence, this is something that we frequently offered. So people could learn in much more detail than today, how exactly do I get my individual assessed for DD supports? How exactly do I access those emergency mental health services when they're needed? It really helps when there are official partnerships and agreements for cooperation and modeling from leadership. So the director of DODD, the director of mental health, the county board leaders, when those folks are partnering, when they show up at things together, when they encourage particular projects or initiatives, what leadership is paying attention to makes other people pay attention. And so I think that kind of modeling is really important on the leadership level. And then finally, this is one of my favorites, and that is local and regional relationship building. Too often that only happens when someone is causing problems, to be honest. So we've got Joe who's showing up at the emergency room. He's showing up in the drunk tank. Cops are picking him up. He's la, la, la. And that kind of forces people to start talking to each other, but that's not always a great vibe. I think that's really important in those situations, but we can also be more proactive about that. And one of the things that I saw, especially in some of those regions where they had multiple small counties, was there were a couple of teams that would host a quarterly breakfast for some of those CPST folks and SSAs and frontline staff, and they could just come and have breakfast. And maybe there'd be a little bit of a information sharing or something, but it wasn't a team meeting, it wasn't a staffing. They didn't all have to sit there and listen to somebody. They could just eat donuts and bagels and meet each other. And this was incredibly effective because that way, when someone was, I don't know, Joe gets turned away for emergency psych services, instead of just getting upset, the DD supervisor can call and say, hey, Susan, what's going on? Let's talk about what happened with Joe and how do we want to handle this and what can your folks do and how can we help and how can you help us and la, la, la. When there's a relationship, it's always easier. And so in large counties like Franklin County, that can be a little trickier, but whatever way is available, whether that's, I don't know, like we did a listserv at one point, which is sort of outmoded now, but they can be virtual get-togethers, they can be in person. When people know the other counterpart that they have on the other side of the fence, a lot of problems can get solved before they build up. So these are some things that I recommend because we really are like cousins in the same family. We may make the potato salad a little differently, but there's a lot of overlap. And the most important one for me is how dedicated we are to helping the folks that we serve. And I'll end with this lovely quote from Maya Angelou, and this has guided me no matter what field I'm in or no matter what topic I'm talking about, that while there are absolutely specifiers in context or in various conditions that people can have, or culture or ethnicity or whatever it is, those are important and deserve space and time to learn about and become proficient in. But for me, my guiding principle is we are all more alike, my friends, than we are unalike. And I think that goes for our two systems as well. So we'll take a few minutes for questions, but again, thank you guys for attending this. This is really the most important part. I've been delighted and honored to get to spend this time with you. Thank you again, Holly and Elena, and your supervisors and folks that went ahead and put this together. So let's jump ahead to some questions really quickly. It seems that other diagnoses appear, or new diagnoses appear in the elderly. Is this true? It absolutely can be, Brenda. And again, we've got that sort of, you know, those threads we need to unravel a little bit about, is this a neurological decline that we're seeing, or a neurological effect? Is this an emerging stressor environmentally that's not being supported or identified fully or appropriately? Or is this a new mental health issue? Swallowing coins, could that be pica? It could. You really want to look at the intent. So if that person is saying, I want to kill myself, I'm going to poison myself, and they think that coins will do that, then we would identify that more as a suicidal gesture or suicidal attempt. Nicole's talking about using EMDR, and it's worked so well with her clients in the spectrum. Nicole, thank you so much for that. That's awesome. I've been hesitant to use EMDR with my clients for intellectual disabilities, want to ensure that they understand and are comfortable with all of the modalities used. I have a client with a recent trauma with an intellectual disability. Explaining EMDR would be a barrier, as I'm not sure the client would fully understand the EMDR process. I'm willing to try, though, as I do believe EMDR is a wonderful tool with trauma. How would you suggest explaining EMDR to a client in terms of understanding? Oh, Nicole, that could be a really long conversation about that one person. And it seems like you are already very in tune with that. I think that sometimes it can be beneficial to just jump in and see what's going on. And using so if you begin this conversation, and I want to be very clear here, I do not equate adults with intellectual disabilities with neurotypical children, but I will say sometimes that can be helpful to look for model clues. So people who do EMDR with children, how do they approach that? As a starting place, to be very clear. I would also say that some of those interview techniques that we talked about, like, you know, maybe talking a little bit in simple, concrete language and then asking questions, or if they're verbal, asking you to tell them what they've heard you talk about. If you get, for example, an answer of, yes, I understand, or yes, I'm okay with doing this, leaving that, maybe coming back to it at another time, seeing if that has been enduring as an understood across the time. So obviously those are not answers. I think you are well on the way, as I said, to being an expert in terms of this individual, but those are some things I might think about to start with. Let's see if we've got anything else going on here. One of the main problems from the mental health perspective is sometimes we notice a DD diagnosis after the cutoff age, and then it is nearly impossible to get them linked. Sean, yes, that is an issue. When someone is getting a full evaluation, if you can demonstrate through documentation that whatever problem has been observed, even if it maybe wasn't identified prior to the cutoff age, or there was an injury that's suspected, a traumatic brain injury that is maybe causing the problem, that can be documented before the cutoff age, that might mitigate that. Nicole, you're amazing too. Thank you so much. Can you show the slides of cognitive symptoms again? We will make these slides available to you guys. So hopefully that will make this easier. They'll be a little more condensed, but that's something that you guys will have access to, Lisa. So hopefully that will help. Any resources, readings, approaches for co-occurring substance use and mental illness and DD in adults? Len, this is still a poorly understood area. But there are some resources in terms of the DMID does address substance use. There's another book I've listed in my resources that is a handbook for clinicians for psychiatric use that talks a little bit about substance use. And there are there is some literature, so I would look there, but we're still really working on that. Generally speaking, I would say presume competence and work with support people around that individual to modify existing resources is usually a good place to start. Certainly, I think that that's better than not allowing services at all, right? So that's where I would start and kind of see how far you can get. I know we're over our time, so I'm going to stop that there. I'm going to go ahead and stop the screen share. Thank you guys so much. This was a delight. I don't know, Holly, if you've got any parting words for folks, and I think we'll go ahead and leave it there.